So Jazz, what's up for today's episode?
Well, June is National Men's Health Month, and so that's what this episode is all about.
What exactly, men's health is a broad topic, I think. What exactly are we going to be talking about?
Well, you know what we're just going to be mentioning several body parts today that have never really been said on Eat, Move, Think before. Let's just put it that way.
We're talking about the health of the male reproductive system.
Yeah, so we can't really avoid these words today.
So what are the...
I'm just going to get it out there. We're talking about testicles.
And the prostate.
Yeah.
And the reproductive system in general. Hey, I'm Chris Shogan. I'm executive producer of Eat, Move, Think.
I'm Jasmine Ratch. I'm managing producer. And it is true. Maybe this awkwardness that we're feeling when we're talking about the male reproductive system is part of the reason that men's health is a topic that people don't really tend to know much about.
And so this reluctance to talk about, which we're sort of dancing around, the health of the testicles, of the prostate, this is stuff that is important and real and can save lives if we just kind of remove the stigma around it.
Yeah, so that's what we're working towards here. I spent some time talking to men here in Toronto, and a lot of them were surprised to hear the facts about the male reproductive system. And we'll be including clips of that tape throughout the episode. Did you know that testicular cancer is the most common cancer in men aged 15 to 35?
No, I didn't hear about that.
No, I didn't know.
It's good to talk about the serious issue, but actually I don't know much about the cancer.
I did not, actually. Maybe it's worth paying a little bit more attention down there.
To help provide some context around men's health, Medcan Chief Medical Officer Dr. Peter Nord is back to chat with Dr. Rajiv Singal. He's the Director of Urology at Medcan and the Chief of Surgery at Michael Garron Hospital.
They get into the latest developments in testicular and prostate cancer prevention and treatments, and a new therapy that could help cut down those nighttime bathroom breaks that may have been keeping you up.
Here's Dr. Peter Nord.
Hi there, I'm Dr. Peter Nord, a frequent host of Medcan's Eat, Move, Think podcast, and I'm delighted to welcome to the podcast today my friend and colleague, Dr. Rajiv Singal, respected urologist and, in fact, our clinical director of urology here at Medcan. We're recording this in June, and it's important because this is Men's Health Month, and so we thought it would be appropriate to have a wide-ranging conversation on the topic of just that, men's health. What is it? How do you encourage it? And what's happening in terms of some innovative treatments for the various conditions that fall under men's health? And first of all, Rajiv, how are you doing today?
Oh, I'm very well, Peter. Thanks for inviting me here today.
Great. Well, let's just jump into it. I mean, a lot of people hear the term men's health, and they often don't know exactly what that means. I mean, a lot of my patients just think we're talking about that magazine that sits on the store shelves, Men's Health magazine. When we say men's health, can you tell our listeners what exactly that refers to?
So I'm a urologist, and so that tends to often refer to sort of, urology type issues, which of course, we are caretakers of a lot of specific things that only affect men. But the way I really look at it in my role as a urologist is a larger piece around how can men advocate for themselves, right? How can they look to live a balanced, healthy, happy life and know where to seek out care where it needs to be? I think our female counterparts probably do a better job, I think, as a rule, in terms of asking questions and looking for access to health care. I think men tend to not always look for opportunities to seek out advice. And so I think most of all, it's that, right? It's creating a forum and an opportunity for men to be able to look for all aspects of their health, which includes cardiac disease, cancer screening. It could be a variety of different things.
Yeah. And of course, as a urologist, you're focusing on one part of the male anatomy. Why don't we just start with a little bit of the discussion around the prostate? Because I think a lot of people may not know exactly what that is. So maybe we'll just jump in and just talk a little bit about, the prostate gland and what it is, where is it, and what does it do?
Sure, no, that sounds good. I think so. Obviously, when it relates to urological diseases, the prostate and all things related to the prostate are really central to what we do as urologists. So, the prostate is a gland that is a part of the reproductive system in men and has a role to play in fertility. And so, it has a role in producing semen, which is needed to transport sperm, and has a role in liquefying that sperm. So there's a fertility component that is very normal. So we're born needing a prostate, and a lot of it's clinically useful role in life tends to sort of be done relatively early, and there it remains afterwards. And so as we get older, it tends to then create a series of things that can lead to symptoms, nuisance, or potentially something much more concerning. And so we would often talk about the prostate growing or enlarging as time goes on. And of course, I can talk a little bit about prostate cancer as well, and in terms of how we may look and manage some of these things and what to look for.
Yeah, we'll definitely unpack the whole prostate cancer thing, and maybe then a little bit about the testicles, because they're pretty close to the prostate, and maybe you could just say a little bit more about what the testicles do.
So the testicles are an organ that has a dual function, right? So they have what we call an exocrine and an endocrine function. One, of course, is to produce hormones, testosterone. So a normal and a very important piece that all men need to have to maintain bone health, a sense of well-being and energy, have a sex drive, and so we need testosterone to live a normal, healthy adult life. And but the testicles also have a role in fertility. So we talked about the prostate and the transport medium, if you will, for sperm, and of course the testicles themselves produce sperm, and that's a central and a very important critical component, obviously, in the whole process around the fertility.
Yeah, and I think one of the things that I've noticed, and I counsel patients, especially if they're coming through for the annual health assessment and they're sort of in those younger ages, they're often struck by the fact that testicular cancer, which you really don't hear much about. I mean, we hear lots about colon cancer and prostate cancer and breast cancer and very little actually on testicular cancer. And it is not an uncommon cancer, and it's quite devastating. And the big takeaway for me when I'm counseling patients is it can affect men in their 20s and 30s. In fact, the men that develop testicular cancer are quite young, just getting their career started, just getting their family started, and all of a sudden, this thing happens that they had no idea about because they really hadn't heard much about it. Maybe you can just talk a little bit about testicular cancer and, what can we do to screen for it? What can we do to prevent it? And then if there is something there, what would be the next steps? Just a little bit of sort of testicular cancer 101.
For sure, Peter. Thank you for that. So, I mean, certainly relative to other cancers, testicle cancer probably is less common. But as you quite rightfully alluded to, the fact that it impacts younger men, it has an impact that is in many ways disproportionate to what you might see. And in fact, even younger, I mean, you might see mid to late teenagers that have an impact. And what I would say, and from a screening perspective, the good news is the testicles are easy to find, and just examining oneself, whether it's in the shower or at some other convenient place periodically, once a month, every few weeks, just to look for any new lumps or growths, and I think is really prudent. And I think if you feel something that is new and different, then I think it's important to seek medical attention in that circumstance.
So when's the last time you did a self-exam for testicular cancer?
It's been a long time.
I don't know.
Probably every time I hop in the shower, check myself out, and just see what's going on.
Every now and then. I mean, I do check here and there, as you probably should. So that's a plus.
I've actually never done one. Probably now I would. Actually, I think like most guys, we've all kind of maybe felt something down there before and been alarmed and Googled around. So I feel like I've done that. I think that since that happened, I've been a little bit more cautious about it, like subconsciously.
That's good.
Yeah.
The good news story with testicular cancer is it is in many ways one of the great successes in oncology, and one can catch it, and with the combination of other treatment modalities beyond surgery, which is a critical first component, that we can often still have a very good outcome. And there's some good information. There's a lot of stuff online. Testicular Cancer Canada is an advocacy group, and there's some nice information things that you can find there. Everyone knows the story of Lance Armstrong. Had a very significant and advanced testicular cancer and was able to be treated and went on to do very significant things. And so regular examination, look for something new, any new lump or bump, and get checked out. That would probably be my advice around testicular cancer, especially if you're a younger man.
Yeah, and I guess too, the other takeaway is if something is felt, something that's a little unusual, simple test, just an ultrasound would be one of those next steps. And the ultrasound just kind of looks inside and says, is this abnormal or normal or something in between? And you can get an ultrasound anywhere. So it's not as if this is a very difficult thing to take the next step on as well.
Absolutely.
Okay, so let's change tacks just a little bit, and let's sort of a common scenario where there's a patient, a gentleman in their 50s or maybe early 60s, and they're starting to notice that they're getting up at night to void. And, at first it's once a night, and then twice, and then it's like 3 times a night, and then it's affecting their sleep, and that means their performance the next day is suffering because they're kind of sleepy and they haven't been doing well there. And what's going on there? And that's a common thing. Maybe they also notice that their urinary stream isn't quite as strong as it was at one point. So you get these all the time. These are people that are coming in with some of these symptoms. What do you say to those folks? And for the men that are coming in with those sort of symptoms, how do you approach that, and what are the next steps?
So, certainly I think as urologists, we often will just think about this as plumbing, right? And in the human body, you have the bladder, which functions as the pump, and then you have, the bladder outlet. And so as men get older, the one common thing we see, and which is a normal response, and it's a benign process, and it's likely hormonal driven, is that as one gets older, your prostate grows. And as your prostate grows, it has the effect of constricting the urethra, the pipe through which we void. And so that will manifest itself with some of the symptoms that you talked about, right? As it relates to a slow flow. And if the bladder is maybe not, the pump is not efficiently pushing against it, you might end up with leaving urine behind, which then translates into more urgency and frequency and getting up at night. And so the process is benign. It's a benign condition. To some extent, we're all going to have a little bit of BPH or benign prostatic hyperplasia or enlargement as we get older. But how we manage it is a conversation that we need to have with our patients, and around how bothered they are, right? And this is kind of where the advocacy piece and getting back to men's health, and I think a lot of men might not even seek out treatment or even advice because they may immediately jump to something that this is something bad.
June is Men's Health Month. Did you know that?
I did not, actually. I didn't know that.
No, I do not.
No, I didn't know.
Why do you think people talk so much more about breast cancer than they do about testicular cancer?
I feel like guys, a lot of the time, I feel like they're more private about it. They might try to hide it as well. It sounds like it could be a little bit stigmatized. It's associated with your manhood, like it has something to do with maybe losing your manhood or something like that.
As a general rule, we may manage some of those symptoms from doing nothing and providing reassurance to maybe managing things that irritate the bladder. If things continue, there's a series of medications that can help to manage these symptoms. And then beyond that, we are, as urologists, in the business of unblocking pipes. And so there's a number of procedures that I'm happy to speak to.
And then, I'm sure for many men, if they have the symptoms, they're going to start with their family physician. They're going to visit their family doc. And sometimes, not infrequently, they may be asking for this PSA test, or a prostate-specific antigen. And so I'm sure you have men that come in with some of those symptoms and a PSA level that is marginally elevated, which is concerning because the PSA test is designed around cancer screening, like it's a cancer test. So if that prostate-specific antigen is up, it was designed around identifying cancer early, but it also can be elevated just with that BPH, or the benign prostatic hyperplasia as well, right?
Oh, absolutely. And so PSA, to be very clear, is a normal protein that is made by the prostate. And what we do in clinical medicine is we use it as a way to try and make some judgment as to who might be at a heightened risk for prostate cancer or not. But I think the good way to think about it is, we're measuring basically what is in the bloodstream, or what sort of leaks out of the prostate. But I think, just as you said, if you have a larger prostate, it stands to reason they're going to have a higher PSA just based on that. And so, that creates always a little bit of confusion in terms of, well, what PSA is normal? Well, the answer is it depends, right? It depends on are you symptomatic, which might imply that your prostate's a little bigger. Has your PSA changed? And so when we use it as a cancer, not a screening tool, but as a way to make some judgment around prostate cancer risk, we usually look at a number of factors that would include making a judgment as to whether the prostate's bigger, because I might accept a higher PSA on that basis, whether the PSA's changed over time, is there a family history. And so that's probably the main thing I would stress, is that it's a little less black and white. The most important thing I would say around PSA, and this again just speaks to advocacy and promoting good health, is I think it's important as men get to be middle-aged, 40-something, 40 to 50. Yeah, it's good to get at least a baseline test done. And I know we do that at Medcan, and it's something that I go out of my way to try and promote everywhere, right, around the importance of getting a baseline, so that if you have another one done at age 55 or age 60, the first thing I would look for is, well, what was it 10 years ago or 5 years ago? And so I think that's probably the most important take-home message, I think, around PSA.
Yeah, and that's something that we try to do at Medcan. And so if we go back to our bit of a clinical scenario, we've got a gentleman in his late 50s who's starting to have some symptoms, and his PSA has come back and it's marginally elevated. And what you're saying is it could be this BPH, or it could be potentially early prostate cancer. So why don't we go down each of those paths for a little bit? So let's say you're thinking, based on the information that you have and a digital rectal examination, that it's an enlarged prostate. Is there anything else first, I guess, that you can do to differentiate that you're going down that treatment path versus the prostate cancer treatment path? And if it's the BPH, what's the next step going down that path?
Yeah, so in terms of making a prostate cancer diagnosis, you need tissue. You need to do a biopsy. And so usually somebody who just comes in with a stable PSA and some symptoms, it's likely just a benign sort of growth. And if there is, a very early prostate cancer, it may be something that we'll just make a judgment we're going to follow anyways. I think our population of patients at Medcan are particularly hardwired to be very proactive. And, certainly, we know there are bladder irritants, and, caffeine and alcohol, just to go back to those, are two sort of very classic things. And, I often use this phrase, life's too short to give up the things you enjoy. But, again, maybe a little mindfulness, right? Maybe a smaller glass of wine, or maybe one less coffee. I mean, it may be all they need to do. There are generally two classes of medications that we can use to treat men. One is what we call alpha blockers, and men might know these, and they go by certain names. You might hear about something called Flomax or Rapaflo or Zatrol. Those are the three common drugs that are often prescribed. They don't actually do anything to change the prostate shape or affect growth, but they're very good at actually ameliorating symptoms, at improving symptoms. And so a lot of men will say, I want to try something. And they work very quickly. And so the upside to that is you can often see a scenario with a clinical improvement very, very quickly. There's another class of drugs called 5-alpha reductase inhibitors, and they go by, typically two common drug names. One's called Proscar and the other's Avodart. They basically work the same way, and over time, they will work to either slow down growth. In some men, you may see some prostate reduction, size reduction, but I think they'll often work to kind of slow growth. And so that's kind of the next stage, right? And you have these conversations, and it's a very much an active mutual back and forth that we would have with the patient, or you would have with the patient around in the context of this benign disease. Do we want to try these kinds of things? And then as things progress, there are a group of men who then need intervention. And so the general indications for intervention are either a failure of medical therapy, a desire to get off of medications. There are a group of men who will say, it works pretty well, but I really want to get away from some of the side effects or just the hassle of taking a pill. And so there's obviously a number of things to consider. Most of these live in the realm of what we call minimally invasive surgery. We tend not to make surgical cuts. A lot of this tends to be done through scopes that we can place inside and through the penis to sort of open up or unblock that part of the urethra that runs through the prostate. I think a lot of our men will read about something called a transurethral prostate resection. So that is what we like to call the gold standard, right? In terms of, what we've been doing forever, right? Certainly for decades. A tried and true operation that basically opens up the internal anatomy to create less resistance, and it works very, very well. And then there are some newer things that are now, potentially worth looking at. Can we take something that's minimally invasive and make it even less invasive, and then maybe reduce some of those side effects? So I'm happy to speak to a couple of those as well, if you'd like.
Yeah, why don't you jump right in there? Because it's something that's between kind of the medication side of things and having to go for the full transurethral resection of the prostate. And just over the last couple of years, there's been some really kind of exciting and innovative things happening in sort of that in-between stage.
Yeah, exactly, right? So there's a couple that are worth talking about. There's one that I'm pretty high on, but, essentially, what can you do to open up the passage in a way that doesn't require cutting tissue and a formal anesthetic and some time in the hospital? And so there are a group of guys who really want to be able to do something, but maybe avoid some of that extra grief that comes with doing a transurethral prostate resection. There's one that we have been offering a lot of our Medcan patients lately called Resume, which is basically using water vaporization therapy, basically steam, little pellets of steam with a minor anesthetic that has the effect basically of destroying some of that tissue and opening things up. There's a device called UroLift that some men might look at that doesn't actually remove tissue, but for some smaller to mid-sized prostates maybe has a role to play in essentially almost sort of stapling the prostate open. And so that has a role, I think, but not necessarily a really easy role for, when the prostate gets to be bigger.
That's really exciting stuff. Nice to have some of those innovative things to offer men at a time they may not know that there's even these other options. So let's now go down the prostate cancer path. Maybe you can describe, how the biopsy procedure goes, just to create a bit of a picture of that, and let's say that, you do actually find something. So you've biopsied and there's a positive response. What happens next after that?
Sure. No, that's great. Thanks for that. So the first thing I would say is prostate cancer is actually very common. Upwards of 1 in 7 to 1 in 8 Canadians over the course of their lifetime will develop prostate cancer. So that seems like a big number. The challenge with prostate cancer is that many people do not need to actually be treated, right? It can be slow growing for some people, for the majority of people. And so the holy grail is trying to figure out before a biopsy where we take some samples, not am I going to find prostate cancer, but am I going to find, for lack of a better term, real disease? The reason we want to be thoughtful is biopsies have some risks. We typically insert a probe in the rectum, and with some freezing, we then use it to kind of guide a needle and take some samples of, that we then send off to the pathologist to get checked. So there's information in the biopsy itself based on, and we use something called a Gleason score that is just basically a way of measuring what things look like under the microscope to make judgments as to whether that should be treated or not. And, the biopsy gets done. If it's positive, I make a judgment based on how much we're seeing in the biopsy, what the Gleason score is, what the patient's health is, right? A 40-year-old or a 45-year-old, you might manage differently than somebody who's 70 or 75 years old. So that's the next step. And there's no doubt it's a very important, very deliberate conversation you need to have with patients, because oftentimes they may not get past you've got cancer. And so the worst thing to do is to make unnecessary decisions around treatment with potential side effects, if all you really need to do is spend some time explaining why in this particular instance, I may just simply follow you. So that's sort of prostate cancer. And of course, on the treatment side, again, a very long, complicated conversation that usually I think the one thing I would say, men should take some time to review all of their options. I think there's surgical options, there's radiation options, and, they have their pros and cons. And those decisions around prostate cancer treatment, it isn't just fixing the prostate cancer, but what are their goals? What are their relationship goals? There are some quality of life impacts to prostate cancer treatment that need to be vetted and explained and understood from the patient's perspective before you embark on anything.
Perfect. Maybe just to round out that discussion, sort of 60 seconds on genetics and the role of genetic screening when it comes to prostate cancer.
Yeah, so I think it's evolving, right? So I think we're finding more and more opportunities to look for mutations that will harbor a heightened risk for prostate cancer. And of course, Medcan has been very much ahead of the curve on that. The holy grail, of course, is there a signature gene where you could say that is associated 100% of the time with real disease, and then for everybody else, you could leave them alone. We haven't quite got there yet, but as a sort of an additional adjunct, an additional tool, I think it can be very, very helpful. And I think it's going to continue to evolve. It's an exciting space. The BRCA1 gene, that we often will see and associated with breast cancer, is something that is very much associated with men who can potentially have a significant prostate cancer. So you do need to be very careful with certain. There's a larger gene pool you can look at, but there's certainly a couple of things like BRCA that we look at. If you're unsure about somebody, that would be the thing that would probably lean you towards saying we got to check you out and do a biopsy.
Yeah. I think the takeaway for me that you said a few times here is it's a conversation. It's very individualized. You can't lump everybody into the same buckets, and everybody's different.
Why do you think people talk so much more about breast cancer than they do about testicular cancer?
I don't know. I think guys just don't generally talk about that sort of thing in and amongst themselves.
I feel like men have a tendency not to do health checkouts. Like men think they need to push through the pain and through things. They don't want to go to the doctor. They don't want to get checked. That's kind of culturally how men used to be in the past and how we still keep being.
Probably because I guess there's a big like stigma around like men's health in general, whether it's like mental health or something like this. Whereas, I mean, nowadays people should be more open to talking about it, and it's something that should be openly discussed.
So hopefully we'll move toward more of an awareness for men in terms of their health and mental health as well.
Yeah, absolutely, and we need to. Right?
Yeah. I've had patients in their later life, and they've had prostate cancer. It's spread, it's gone to their bones, and they're actually out golfing still. I had a patient in my practice he was able to, despite having metastatic prostate cancer, was golfing his age. So he was 80, shooting 80, and if you looked at his x-rays, you'd say, oh my gosh, like this is impossible. He's in palliative care. So there's a few of those great examples that just go to the fact that it's a very, very individualized condition. I guess the other aspect of men's health that happens as men are aging is erectile dysfunction as well. And it's often, a very sensitive subject. Many men suffer in silence. It becomes a communication issue. It's relationships. It is something that they're a little bit, shy about. And so maybe you could just talk a little bit, just a few minutes about erectile dysfunction, what causes it, what can we do to prevent it, and maybe a little bit about what are the treatments are that can actually make a difference.
So I guess I would maybe just start by saying ED or erectile dysfunction in particular is not an easy conversation for men to have. And so if we can create a comfort zone so patients, for men can start to not suffer in silence and maybe seek some help. So there's lots of different causes for erectile dysfunction. I mean, and I think a lot of it lives in a conversation that men should have with their primary care physicians. There's a lot of complex things that live outside of our purview as urologists around stress at work and relationship factors. I mean, it might be something that is entirely managed, through identifying and then working through a new life stressor that might have evolved. And so, but from a physiologic, from an organic perspective, you need hormones, but by and large, I think if we can stress one thing, a lot of erectile dysfunction can be a vascular disease. You need a blood supply and a blood flow to get an erection. And so what happens as men get older is there's an increasing challenge. And one of the reasons is that presumably the same things that affect blood flow to other parts of the body can affect the blood supply to the penis. And so a lot of us will think of true physiologic erectile dysfunction as maybe the first warning sign of emerging vascular disease. And so if you think of the arteries to the penis as being pipes that are that much smaller than what's in the heart, it stands to reason that a smaller pipe is going to get blocked faster than a somewhat larger pipe. And so all of the things we would do to counsel men around optimizing vascular disease would then apply to this. So if they smoke, stop smoking. If they're diabetic or hypertensive or their lipid levels are a little bit higher, get all of those kinds of things in control. If you see that and it's coupled with a history of premature vascular disease or heart disease in one's family, again, that may be a red flag and a conversation to have with you or another primary care physician, Peter, around, well, maybe we should, be a little more aggressive around cardiac screening. Yeah, everyone's different, right? Relationships are complicated and, work life is complicated. I mean, all of those things, it gets back to health awareness and advocacy. And, I think, as men get older, you don't want to smoke, you want to exercise, you want to sleep well, manage stress, don't put on too much weight, and get your cholesterol levels checked. We need men to make sure that their primary care physicians are also addressing the prostate side, doing that blood test, getting that baseline so that we can then establish what that risk might be. I think that's the main thing, is be aware, don't suffer in silence, ask questions the next time you're in to see your family physician. And I think that's ultimately what Men's Health Month is all about.
So in honor of Men's Health Month, what's something that you do regularly for your health that you would recommend other men should try out?
Oh, just trying to keep active and watching what I eat and thinking about long-term health and how my decisions in the present will impact me later.
Yeah, I'm a very active person. I do jiu-jitsu 5 times a week. I lift weights, do calisthenics, try to eat healthy. I've been vegan for 7 years now. Wow. Yeah, I'm just trying to take care of what I eat and how much exercise I do.
So checking for something like cancer would be something that would help you keep up your wellness.
For sure, yeah.
I mean, it's a little something I do. It's not that crazy, I guess, but as soon as I get up in the morning early, I do make a coffee and walk of the block. Kind of clears the head and sets me up for the day, get some early morning sunlight.
I'm regularly trying to quit smoking cigarettes. Yeah, but also try to eat healthy, and I exercise as well.
Awesome.
I ran a marathon recently.
Oh, congratulations. That's amazing.
Thank you.
I mean, what would you say to men listeners in terms of their lifestyle? I mean, what can they be doing to live healthy to prevent these things from happening?
Yeah, true prevention is hard. I mean, if you maybe extend it to another cancer we look after as urologists, bladder cancer, then that's certainly another not an uncommon thing. I mean, the biggest thing there is smoking, right? So that's certainly something you can do to lessen, if not prevent, one's risk. There has been a lot of excitement in the past around foods and the role of antioxidants around prostate cancer prevention. I can't say credibly, Peter, that there is any clear point from A to B where if you do this, you will not get that. So I think it really comes down to awareness more than anything else. But a lot of the stuff around diet, really gets, again, looking at men's health more broadly, if you eat well and eat in moderation and sleep well and exercise, I mean, it's probably going to have some impact in a positive way on your prostate. It's sure as hell going to have an impact on your cardiac well-being. And it's really advice that just is applicable, I think, and is common to all of those. And so I don't know if there's any specific dietary measure, but I suspect there's probably a link, and what's good for your heart's probably good for your prostate.
That's a great way to leave it as well. Certainly men's health is certainly more than testicles and prostates. As you said in the opening, it's about heart and lungs and all that other thing. But you're a urologist. We really wanted to pick your brains and your expertise because this isn't simple. As we said, this is very individualized. And that's why I think there's a lot of questions. We get a lot of questions all the time about these sort of things. And you can't just create an algorithm and follow the algorithm. It's very individualized. So I think the future is really bright for this part of medicine and for men's health in general. So super having you here. Thank you so much for those tips. You're the voice of experience. You've been around the block a few times with these things. You've talked to thousands of men in your career. And it's just a pleasure to have you here at Medcan. And I know our listeners, I'm sure, really hung on every word, lots of insights. Really appreciate your time, Rajiv, and have a great day.
Thank you, Peter. Thank you so much for inviting me, and you have a great day and a great summer. Do a little self-care yourself.
That was Medcan's Chief Medical Officer, Dr. Peter Nord, in conversation with Dr. Rajiv Singal, Director of Urology and Chief of Surgery at Michael Garron Hospital. Follow Dr. Singal on Twitter at Dr. R.K. Singal. That's DRRKSINGAL.
We'll post episode highlights and links that you can visit on our website, eatmovethinkpodcast.com.
Say hello and send us a tip or a suggestion by emailing us at info@eatmovethinkpodcast.com, and follow Medcan on Twitter and Instagram at MedcanLiveWell.
Eat Move Think is produced by Ghost Bureau. I'm managing producer Jasmine Ratch. Social media and strategy support is from Chantel Gertin and Andrew Imax.
I'm executive producer Christopher Scholgen. We'll be back soon with a new episode examining the latest in health and wellness.
This podcast is intended to provide general information about health and wellness only and is not designed or intended to constitute or be used as a substitute for medical advice, treatment, or diagnosis. You should always talk to your Medcan healthcare provider for individual medical advice, diagnosis, and treatment, including your specific health and wellness needs. This podcast is based on the information available at the time of preparation and is only accurate and current as of that date. Source information and recommendations are subject to change based on scientific evidence as it evolves over time. Medcan is not responsible for future changes or updates to the information and recommendations and assumes no obligation to update based on future developments. Reference to or mention of specific treatments or therapies does not constitute or imply a recommendation or endorsement. The links provided within the associated document are to assist the reader with the specific information highlighted. Any third